Okay, when to use oxygen therapy. So, kind of the first step in our patient case scenarios is determining whether or not someone needs oxygen therapy. As I said before, oxygen is a medication. So, do they need it? Indications. How much do they need? Low, moderate, high concentration of FiO2. Is it emergency or routine? Are you changing from one device to another at the same FiO2? What hazards of therapy are we going to consider? Um, and then what device do you choose if they do need it? Ability to meet patients' needs, reasons to avoid it. So we're going to kind of talk through that whole process. Indications, hypoxemia, PaO2 of less than 60. You guys are very familiar with that. SaO2 or SpO2 of less than 90 on room air is less than a desirable range for clinical situation. Other scenarios that you're going to need it are CO poisoning or suspected CO poisoning, myocardial infarction or MI. Traumas generally get put on a couple liters just because of everything going on. It's just kind of a protocol they put them on. Anytime you see the words chest pain, you're always going to usually put them on a couple liter nasal cannula. If they have a presence of clinical signs or symptoms, cyanosis, tachypnea, tachycardia, these are all things that you would throw them on oxygen if you didn't have any other information at the time. We also use it a lot as short-term therapy. So people are often placed on a couple liters post-operatively as they're waking up because they're shallow breathing, maybe not getting as much oxygen as they normally would. So they kind of end up being low flyers until they wake up. Also, whenever somebody is being dialyzed, they get put on 2 liters. It's just support for the process that they're going through. So there's definitely a couple different indications for why you would use oxygen. Precautions and hazards of high FiO2. And I really want to draw your attention to the high FiO2 here, okay? Now, we talked about these hazards in cardiopulm, but we're definitely going to spend some time reviewing them now, and they're going to come into play for your exam. So oxygen toxicity, this is caused by a high FiO2, primarily affects the lungs, can cause central nervous system damage. Determining factors include the FiO2 and the exposure time. Your target is always going to be, if possible, an FiO2 of less than 50%. Kind of the rule of thumb is if they're on 100%, we really try to get that weaned down within 24 hours. If they are on 70%, we try to get that down within 2 days. And then if they're on 50%, we really try to get that weaned down within 5 days. These are kind of the exposure times that we use as a rule of thumb. Obviously, that's not always possible. But again, I mentioned how oxygen treats symptoms, not the underlying issue. Our goal is to always try to treat the underlying issue so that we can reduce the FiO2. That is a big, big portion of our job. The other O2 hazard of high FiO2 is absorption atelectasis, and this is something that we talked about in detail in cardiopulm. But basically, if you think about what room air is comprised of, it's comprised of 70-some% of nitrogen. When you have FiO2s that are above 50%, what happens is you wash out that nitrogen. Well, the nitrogen is essentially an inert gas that hangs out in your alveoli. It doesn't diffuse, it just kind of stents them open. So when you bring in a high FiO2 that does not have that large percentage of nitrogen, it's all oxygen. What it does is it washes out that nitrogen. When you don't have that nitrogen left over, you don't have that inert gas kind of stenting open the alveoli. The other reason that this will collapse the alveoli is because when you get to the higher levels of FiO2, if you're thinking about Fick's law, which I'm sure you guys are really excited that I brought up, but if you're thinking about Fick's law says that part of what helps diffusion is having a larger gradient. So if you have somebody on a high FiO2, it's going to increase that pressure gradient, and so it's going to diffuse more rapidly. When that oxygen diffuses more rapidly from the alveoli into the bloodstream, it's more likely to collapse that alveoli. So that's what causes absorption atelectasis. Patients that are breathing small tidal volumes already are at the greatest risk for this. So when you think about your post-op patients that are having pain, that are also on high FiO2s, it does not take very long before they suffer a decent amount of lung collapse. collapse, okay? So that's that other O2 hazard. The other two O2 hazards that we're going to talk about have to do with high PaO2, not high FiO2, high PaO2. So you have two that are high FiO2, two that are high PaO2. So depression of ventilation is something we, again, spent a lot of time on in cardiopulm. It can occur in COPD patients that have really severe chronic hypercapnia. It happens because you have that hypoxic drive suppression. So if you guys can kind of remember back that far, when you're somebody who is more reliant on your hypoxic drive, having a high PaO2 can depress your ventilation. And this just happens because COPD patients always have high levels of CO2. Their body compensates for that by retaining bicarb. And because of that, their normal ventilatory drive is essentially blunted. So they rely a little bit more on their secondary system of responding to low PaO2. So if you increase their PaO2 much above 60, you're going to depress their hypoxic drive. If this is not something you can remember, I definitely recommend looking through your notes. The other theory is that you increase VQ mismatch. Normally in diseased lungs, your body kind of has this way of shunting blood towards areas that have naturally more ventilation and higher oxygenation. When you increase a COPD or chronic retainers PaO2 much above 60, what you end up doing is vasodilating those pulmonary vessels, and blood goes to areas of the lungs that maybe don't have the best ventilation. So you're going to worsen their VQ mismatch. Again, if this is sounding unfamiliar, please look through your notes. The other portion of this, and this one is kind of a little bit more confusing because it has to do with the high FiO2. So just be careful when you're reading this. If you happen to have somebody who is a severe chronic retainer who is also on a high FiO2, they're very susceptible to absorption atelectasis, and that can contribute to their decrease in ventilation. That it's still a hazard of high PaO2. This is just a third component that causes it. The other O2 hazard that we are going to look at that is caused by a high PaO2 is retinopathy of prematurity. This causes blood vessel damage in premature infants in their eyes. You guys don't need to know the process by which that happens. I'm not going to test you on it. You just have to know essentially this blurb. It's very important that you try to keep the PaO2 stable. They usually target 80 or less for our premature babies. And I got to be honest, in clinical practice, it's usually far less. But the big takeaway here is that you want that stable PaO2. So this is the same thing, just broken down. High FiO2 greater than 50%. You're looking at these two O2 hazards. High PaO2 more than 80. For COPDers, it's more of a 60 to 80. These are your two O2 hazards that you're looking at. Another way to say the same things. So looking at what device do you choose? Do they need a precise FiO2? What FiO2 do they need? We figure that out with a PF ratio, which you guys are going to see in a different tab. And then will it transport? Some oxygen devices are transportable, others are not. So that's something that we also need to take into consideration. Again, I know I kind of whizzed through that. Part of it is because I did a whole separate tab on oxygen device selection where I take you guys through the different decisions that you're going to make. So I just don't want to make you listen to something forever that's not as clear as it could be until either we have our face-to-face or you guys get a chance to look at those on Blackboard. So that is it for that one.